for me a real pleasure to introduce the speakers of today's talk, which is Dr. Luis Paz-Ares. Dr. Luis Paz-Ares is the chair of the Medical Oncology Department at the Hospital Universitario de Octubre in Madrid. He's also an associate professor at the University Complutense of Madrid and the head of the lung cancer unit at the CNIO in Madrid. He's currently also the president of the ASEICA, the Spanish Association of Cancer Research. He graduated in medicine from the University Autónoma in Madrid and was trained as a resident in medical oncology in the Hospital of 12 de Octubre, also in Madrid. He also completed his PhD in medicine, and he was a postdoctoral researcher, a small postdoctoral researcher in the medical oncology at the Bitson Oncology Center in the University of Glasgow, and completed his master's degree in clinical pharmacology at the University of Glasgow also. Before his current position at the hospital as a chair of the medical oncology in the Hospital 12 de Octubre, he was also the chair of the medical oncology department at the Hospital Virgen del Rocío in Sevilla. He was also the head of the pharmacology unit and responsible for the early clinical trials of thoracic and genitourinary tumors at the University Hospital 12 de Octubre. He was also a visiting research fellow in the prostate cancer program at the Dana-Farber Cancer Institute in Boston in 1999 and 2000. Luis Paz-Ares' research focuses on lung cancer and the new therapeutic strategies development, both at the lab and the clinical sites. He has published more than 340 articles in peer-reviewed journals, including most of them best-class journals in medical oncology, such as the New England Journal of Medicine, the Lancet Oncology, Nature Medicine, etc. He has served as a member of several committees, including ASCO and ESMO meeting scientific committees, the European Association for Research and Treatment of Cancer Protocol Review Committee, an Audit Committee, the Spanish Agency of Medicine and Medical Device, and the European Medicine Agencies. He is the Chief Medical Officer of the ACC, where he also sits at the board. So his CV is very impressive. I am sure we will enjoy very much his talk today. Whenever you want, please.
Okay, so thank you very much, Monse. So it's really a real pleasure to be here today with you. Unfortunately, I'm doing so online. I really be most enjoyable being there, but as I mentioned, we are having a strike of doctors here in Madrid, and we are not supposed to go elsewhere. So over the next few minutes, I will try to...
Yes. Excuse me a second, because I forgot to remember to the audience that they must send their questions to the question and answer button, which is in the screen in the computer. Sorry.
Okay, so now thank you very much. I think it's a very important point that they have the chance to answer any question or make any comment on what I have to say. And we are doing it today during my talk with lung cancer, and it's a very general aspect of about how much cancer are we curing today? Are we making any progress at the time of curing lung cancer? And I'm going to try to give you some data on so. So here are my conflict of interests. And just to give you an idea of how important is lung cancer in terms of cancer issue, I'm just going to give you some refreshing data on the incidence of lung cancer. You know that every year in this country, we diagnose some 380,000 cases every year, sorry, 280,000 cases, and maybe some 130,000 people are dying of cancer. Of those, lung cancer is the fourth in incidence, nearly 30,000 cancers every year, but in terms of mortality is number one. Every year, I would say this year is expected some 25,000 people dying of lung cancer. So as you see, it's number one in terms of mortality. The reason for that is because we are diagnosing lung cancer very late. Only 20% of the patients diagnosed of lung cancer are at very localized stage where surgery is potentially curative. Even though You have a patient with a stage 1 or 2 in lung cancer, and you operate on, then nearly 50% of the patients still die of lung cancer. You compare that with other diseases like breast cancer, colorectal cancer, you have a stage 1 or 2. Cure is happening in some 90, maybe 80% of the cases. So I would say then we are diagnosing a lot of lung cancer, and particularly most of the patients are diagnosed at very late stage. And for that reason, cure rate is very low. The third component is that therapeutics had not been great. Once you develop metastasis, systemic disease, because systemic therapies are not very effective, the outcome is pretty dismal in this very setting. Thank goodness, there are a number of things that had happened, particularly over the last 3 decades, 2 decades. Number one is that we learn a lot about the genomic abnormalities, the molecular abnormalities underlying lung cancer. We know very much, not only of lung cancer, of many cancers, many of the mutation and other genomic aberrations underlying the disease. We know very much which are the molecular disturbances that makes the lung cancer cell to behave differently as compared to the normal lung tissue cell. And because of that, we also learn some of the vulnerabilities, and we've been able to actually take advantage of that. For that, something that had been very important is that the medical chemistry had really advanced a lot, and we are now having small molecules that are having very nice cellular pharmacology. So they are pretty specific. They are good at entering into the cell and inhibiting pretty specifically the target we really like to inhibit. Monoclonal antibodies, they are still more specific. Even they are macromolecules, and you have to use them parentally, but we are pretty good at very specifically inhibit targets. And even gene therapy, I remember when I hear that some 30 years ago, I thought that was science fiction, but today it's a reality. And I mean, we have seen that with the COVID, that we are getting more into the gene therapy as well. Still, I'm just showing this slide because I think it's very important to start my talk. This is a trial that had been presented in early 2000s when we had a number of novel chemotherapeutics, taxanes, gemcitabine, vinorelbine, and so on. And this trial compared 4 chemotherapy regimes, 4 chemotherapy cocktails for patients with metastatic non-small cell lung cancer. The question was, is any cocktail better as compared to the others? And as you see here, the truth is that all the patients really behave very much the same. The important issue is that all of them were really bad. Look at that. At 50% of the cases, 50% of the patients had actually died when 7.5 to 8 months had elapsed. So that means median survival was less than 8 months. That is early 2000 for patients with stage 4. Remember that at this stage, some 60% of the patients are diagnosed with stage 4. And of those with stage 3 or stage 1 or 2, more than half of those patients will relapse with stage 4. So at the end of the day, 80% of the lung cancer patients do have a stage 4 disease at some point. And as you see here, the prognosis was really bad. Thank goodness, a number of things have happened. And I'm just going to try to dissect out a bit of them over the next half an hour or so. The first thing is about a group of tumors that do have oncogene addictions. And I think this is particularly relevant. If we are now concentrating not in the whole lung cancer, but the subset of adenocarcinoma, where this concept of oncogene addiction is a bit more paradigmatic, you realize that today, when we are uncovering the molecular abnormalities of those tumors, I would say 2/3 of the cases do have molecular abnormalities that we recognize as drivers. So we know that there are some molecular abnormalities that dictate oncogene addictions, and they are particularly relevant at the time of initiating the tumorigenesis to happen, and again at the time of dictating disease progression, invasion, metastasis, and so on. And more importantly, today we have specific inhibitors for many of those genomic abnormalities, and they have proven to have a clear impact in the natural history of lung cancer. So today, when diagnosis a patient with lung cancer, my pathologist always looking at the microscope and tell me if the tumor is an adenocarcinoma and the squamous cell carcinoma and so on, but at the same time send some of the tumor to the molecular biology lab to start the genomic profiling of the tumor, because the guiding of the treatment is not going to be based on my inspiration. It's going to be based, for most of the cases, at least for those with genomic abnormalities that are targetable, are going to be based on the genomic abnormalities underlying the disease. And indeed, I'm just going to give you some data, some flavor of why this is important. There are a number of genomic abnormalities that already we have drugs which are actually approved and are within the hospital, the pharmacy of the hospital shelves. So when my patient is having that, I'm just prescribing that very easily. And good examples are patients with EGFR mutations or BRAF mutation or translocation or ROS or ALK. And just to give you an idea, I'm pretty sure all of you are familiar with the EGFR mutation issue. You know, when typically to activate this pathway on a normal cell, you need the binding of the ligand, the dimerization of at least 2 receptors, and then the intracellular kinase becomes phosphorylated and start a number of signals downstream that in the end is promoting proliferation, anti-apoptotic signals, and so on. What happens when you're having a mutation on this kinase portion of the receptor? What happens is that you're having a constitutive activation of this kinase intracellularly, and particularly the pro-survival signaling is on most of the time, and those tumors are really appearing and depending very much on this pathway. And of course, when you're having those cells into culture, depending if they do have or not EGFR mutations, you see that they do respond to EGFR inhibitors, specifically only those tumors that are very much depending on the genesis and on the progression on the EGFR signal. And this massive apoptotic response in the presence of EGFR TKI is actually also seen in the clinic. And the way we see this apoptotic response in the clinic is very easy. You don't need a specific assay. What you really need is an X-ray, and you see typically really amazing response, typically happening in days or weeks. The patient condition typically improves very much in very few days, and this is a typical example. The next step, typically, when you're seeing that in the clinic before that therapy is being adopted by everyone, you have to do a bit more control experiment. That is a clinical trial, a randomized trial where half of the patients are given standard of care treatment, let's say chemotherapy, for example, and the other half are given the novel therapy. In that case, it could be the EFR TKI, and this is the study we have done with Rafael Rosell, that was the Germania Sid Pujol at the time we have this trial, showing a clear improvement in outcome for those patients treated with lorlatinib as compared to chemotherapy, always that the patients were identified were, let's say, by EFR mutations. The second important thing here is that you see even patients with lorlatinib were doing better. At the end of the day, after some time, most of the patients relapse. And we were smart enough, as many other groups, to do some biopsies to those patients. And then we realized that in half of the cases, mutation was given for secondary mutation on the EFR gene. Actually, that typical mutation was affecting the disposition on the ATP pocket, the so-called T790M mutation, really modify the configuration of the ATP pocket so that the EFR TKI is not binding with that affinity anymore, and ATP is again binding more preferentially. Thank goodness, some secondary inhibitors were designed that were binding with high affinity to this new configuration of the ATP pocket. And a good example is osimertinib, and those drugs, this second generation of drugs that are specifically designed to bind the receptor with the gatekeeper mutation, is actually proven to be very effective. This is an example on different genetically modified models, including mice. And of course, when you do the clinical trial, again, you show that this is better than chemotherapy. Those patients that had progressed on lorlatinib with EFR mutation, if they do have a secondary mutation that, as I mentioned to you, happen in half of the patients, those cases are better treated with osimertinib, the T790M inhibitor, as compared to chemotherapy. And since then, this is part of the standard of care. So importantly, we are here not only modifying the treatment and the natural history of the patient once, but at least twice. So you give the first generation TKI, then at the time of mutation, half of the patient have, at the time of progression, half of the patient have a secondary mutation. And for those patients, we use the second generation TKI. Actually, if you do again, at the time of progression, you do again a biopsy on those patients, you start to know what is happening. And then you realize that the heterogeneity is really an issue in those diseases. And at the end of the day, you start to see that the diversity of the clones likely happening from the beginning are really being more evident with the pressure of the treatment. And we realize that at the end, some novel mechanisms of resistance are happening, including some tertiary type of mutations, some of them affecting the ATP pocket, such as the case of the C797S mutation. And indeed, and importantly, we are actually developing now a fourth generation drug, which is a specific inhibitor. And indeed, we are already doing a phase 1 trial with the drug. So hopefully in the very near future, we will have the fourth generation drug coming here. That makes us a very important learning, which is we have to do molecular diagnosis at the beginning before starting treatment, but also dynamically during the course of the disease. We have to monitor what are the genotype of the disease is having our patients, because that is going to help us to guide the treatment of our patient more effectively. Of course, we also learned that if you use the second generation inhibitors, you're getting better from frontline, from the beginning, you're getting better results as compared to first generation. And this is what are we doing today. So you don't treat the secondary mutation, you just give it from the beginning to prevent the emergence of resistance to happen. And we have shown this is pretty effective. And the next logical step is that we are starting to use these therapies, not in late disease, but in early disease. And as you see here in this trial called the ADORA trial, patients with early stage, stage 2, stage 3, after surgery and chemotherapy were randomized to receive the specific inhibitor of TKI, osimertinib, or not to receive anything. And as you see here, those patients without further therapy, they do progress more than 80% of the cases. And for most of the cases, you prevent relapse to happen at least during the initial years if you're giving those patients 3 years of osimertinib. So at the end of the day, we are not only here improving the outcome of a stage 4 disease, because we are using different generations of TKIs that are improving the outcome, but also we are going earlier into the disease, and we are hopefully curing more patients by giving targeted therapy from the beginning. I just put you the example of Fdfr, but for ALK, I'm not gonna spend half an hour here with it, but the example is the same. You're using here, you see on the right, a specific inhibitor of ALK. When you're having a tumor driven by an ALK fusion, you're getting the same results. You're doing better on the ALK inhibitor as compared to chemotherapy. At the time of relapse, half of the patients, maybe a bit less, are having secondary mutations. And then we discover some second generation ALK inhibitors and third generations. And those novel agents are doing better. Not only that, depending on the drug you're having, second, third generation, you realize the profile of activity is different. Some of them are targeting better some type of specific kinase mutations. Some others are better for some others, such as the difficult ones. And I would say here in that example, the typically more difficult one is the 1202R mutation, which is only effective by lorlatinib, indeed. And more importantly, we also realize that first generation is not as good as third generation. Indeed, we are typically now using third generation drugs with our patients because that prevents many of the resistance to happen, or at least they delay those resistance to happen, and is also a lot better in terms of protecting the CNS, the brain, to develop metastasis. And of course, as we mentioned before, we also going into the fourth generation space, and we are having some novel drugs which are now in the TKI, which are effective against most of the known mechanisms of resistance here. And we suppose those are going to be present in our pharmacies in the near future, giving or proportionating further survival guarantees for our patients. Well, I have given to you an ideas of some examples of those drugs that already are in the pharmacy of our hospitals, but there are some new examples that we are having novel drugs, and those novel drugs just have been proven to be successful, and they are starting to be in the clinical trials. They are just starting to be approved by the agencies. A good example are the RET inhibitors, the NTRK inhibitors. I mean, the activity of those novel agents is amazing. They are very specific inhibitors, very low toxicity, and pretty effective. And indeed, we are still discovering every year novel targets and novel drugs. A good example, if the stenocutuzumab drug, which is a monoclonal antibody, truly effective against the small proportion of lung cancer with fusions on the neuroglin gene, that happened in something like 0.1% of the cases, also happen in some of the pancreatic cancer, and we have already data showing this is effective. And a recent paper in Cancer Discovery a couple of months ago also proportionally further data on that. Okay, so we have now some clear evidence that we are improving the outcome of the patients with oncogene-addicted lung cancers, and that is dictating a change in the paradigm of how we are diagnosing lung cancer. So the important issue here is that every time I see my patient in the clinic, I do have enough molecular information on the tumor. I should know not only the first name, but the second last name, the third last name, and so on. So I have to see if my tumor is an adenocarcinoma or not, but also what type of adenocarcinoma, and particularly what is the genotype in terms of driver aberration, ROS translocation, RET translocation, BRAF, EGFR mutation, and so on. And for that, we tend to do a number of genomic tests. Nowadays, we tend to do, if possible, a panel of DNA plus mRNA, so that we are covering all the relevant genomic abnormalities. All the relevant means for all the alterations that are targeted with drugs that are available in our pharmacies, or with drugs that are being explored in clinical trials in our institutions or an institution nearby. We are sending patients from one place to the other because at the end of the day, important thing is that every single patient is receiving the treatment that is benefiting the most. It may happen that your patient is not having enough tissue to do a full genomic annotation. And this is actually happening very often in lung cancer, maybe 20% of the cases. Remember, we typically do biopsies through bronchoscopy, and those biopsies typically are 1 millimeter by 2 millimeters, and very often are necrotics. The content of tumor cell is low sometimes. So very often you recover very little DNA, no RNA, and so on. I think an important complementary tool is liquid biopsy. ctDNA analysis is very important here. This is an example of a trial I have done with some other investigators in the country, where patients that we didn't have enough biopsy, and those patients were not eligible for a secondary biopsy. We did a ctDNA analysis with the Guardant technology. And as you see here, in 15% of the cases, 15%, we discover genomic abnormalities for which we have treatment that we know those are better than chemotherapy. Just to give you an idea. Indeed, for example, every time in my clinic, I see a patient that is a never smoker or a light smoker, I do a genomic analysis on the tumor. Even if the tumor is, if I don't find any genomic abnormality with implications in treatment, I always do a liquid biopsy, because we learn in some more than 10% of the cases, even there is no abnormalities on the genomic analysis of the tumor because of the tumor heterogeneity. If the patient is a never smoker or a light smoker, you find in more than 10% of the cases a target in ctDNA analysis. And this is what we do, and I think more and more people tend to do it. The second issue is about the relevance of the dynamic analysis. Many times, because we are now having first generation, second generation, third generation, and so on, drugs, and many new drugs are coming while the patient is progressing. Every time we have to do more and more biopsies on our patients. And for that, liquid biopsy is going to be of great help. This is a great example. It's a patient from Dr. Ali Shaw from Mass General. That patient has an ALK-driven lung cancer, and as you see here in this example, patients were actually, that patient was treated with third-generation TKI, Criso, nice response. After this response, had a progression after 18 months and received a second-generation drug, Seritinib. Patient didn't respond. Patient was included in a phase 1 trial with a heat shock protein 90 inhibitor, no response at all, and patient was given chemotherapy. There was no other option. After 6 months, short response, the patient was again re-challenged with crizotinib. They didn't know what to do and said, well, that patient responded for 1.5 years to crizotinib. Let's try it again. No responses. Okay. Then the patient was included in a phase 1 trial with lorlatinib, which is a third-generation TKI. And as you see here, those liver metastases actually here, these gray lamps actually decrease in size. Great response. Unfortunately, after a while, after a year or so, the patient developed progression. At the time of the progression, what happened is that the patient was actually biopsied. And as you see, there was a mutation that actually appeared after the initial crizotinib treatment. And then a secondary mutation was also evident, the 1198F. At that time, that mutation profile was predicted to respond to crizotinib, that very few months ago, the patient didn't respond to it. And indeed, as you see below, the patient had a nice response to crizotinib, as you see here. So therefore, that is telling us that if you're having a patient, you really need to do a very close monitoring of the genotype underlying the progression, because you have to adapt the treatment of the genotype that is changing over time. And of course, today we know that you have a lung cancer, you have to do good molecular diagnosis and uncover which genomic abnormalities are there, because if you give the right treatment, target treatment, your patients are doing better as compared to those tumors without targets or actionable targets, or to those patients with targets but are not given the right treatment, because those patients are only given chemotherapy. So you need the right diagnosis to do the right treatment. And this is no way to do it otherwise today. Okay, so we have dealt with oncogene-addicted tumors. We have, let's say, underlined the relevance of precision diagnosis. Let's see what happened with many other tumors which are not as successful. We have some tumors, such as squamous cell carcinoma or small cell, where we do not have targets. Even within adenocarcinoma, we have difficult targets, Carreras, more than 30 years fighting without much success. And then there is the subgroup of patients where there is no clear drivers. What to do with that? Have we done any advance? Do we have any alternative for those patients? And I think we have. The first thing is that even the difficult targets, I think we are able to do something today. The very good example is the G12C covalent inhibitors. Then, you know, we have taken advantage of that specific genotype of G12C inhibitors, because in the GDTP bind is, let's say, is permitting by a cliff the covalent inhibitor to enter there and to sequester the KRAS in the GDP bind inactive state, and the patient or the KRAS molecule is not able anymore to become active on the GDP bind state. The good thing is that you go to the clinic, 40% of the patient responding. Duration of the responders is not years, but is few months, 7 months, 8 months, or so on. So I think we are at the beginning, and importantly, likely we are having very low toxicity because those inhibitors is not binding to the wild type Carreras or not affecting normal Carreras. And secondly, maybe are good candidates for combination therapies with immunotherapy, with other agents targeting the RAS pathway, SHP2 inhibitors, MEK inhibitors, and so on. The problem for me today, again, is those tumors that are not having clear drivers. And this is happening in about some 30% of the cases, maybe 40% of the cases. I mean, dealing with tumor suppressor genes is really difficult. Therapeutically, it's much easier to inhibit ganacy of function as compared to repair the loss of function of tumor suppressor genes. But the good thing is that we are realizing today that we are able somehow of using targeted chemotherapy. The way to do it is by using ADCs. At the end of the day, is identifying molecules that even they are not biologically very important in the tumor cell, they are in the surface of the cell. They serve as a hook to send a monoclonal antibody to bind that specifically, and because we are having through a linker conjugated some biologically active molecules such as chemotherapy, we're able to kill specifically tumor cells without major damage to normal cells. And we have very good examples. We have platforms using deruxtecan, a topo-1 inhibitor, with quite a success in a number of targets. Trastuzumab, deruxtecan is targeting HER2 expressing tumors, particularly HER2 mutated non-small cell lung cancer. You see here nice responses. TROP2 is a pretty well expressed molecule in lung cancer, more than 90% of the cases. Indeed, you don't need really to do any screening to identify those tumors because most of the lung cancer do express TROP2, and some of the ADCs are also pretty effective. There are at least 3 or 4 being developed, and we already have some initial data. The last thing is important to do on those tumors where no clear biomarker exists is sometimes use commutation landscape analysis. And a good example, at least in our hands, in some of our experimental models, is here. We were for a while studying FDfr inhibitors in lung cancer. We realized that many tumors do have overexpression of FGFR1, even FGFR4, and those patients are not responding to inhibitors unless they co-express N-cadherin. So you see tumors with FGFR overexpression without N-cadherin are not responding. When you transfect N-cadherin, they start to respond. Same is true for FGFR response. When you do the contrary, when you actually knuckle the expression of N-cadherin, responding cells are not responding anymore after knocking the expression. And indeed, in some PDXs we've shown this is truly effective. You're not having N-cadherin, those PDXs are not responding to inhibitors. You have high expression of FGFR and expression of cadherin, you see in responses. And if you have overexpression of FGFR1 and 4, then in the presence of N-cadherin, the inhibitor is really, really effective, and you see really nice responses. And I think that may be some of the way to go. So molecular analysis should not be restricted to the obvious target, but maybe some other commutational or co-expressing landscape should be studied. The last thing I really like to maybe mention here, which is relevant, is about taking into account another way of looking at the tumors. Not only tumor is tumor cells, but what is happening around. And of course, if the defenses of the individual, of the patient, would actually be working in every case, most of the tumors, or not a single tumor, would have been diagnosed. So the problem many times is that immunotherapy drugs are not working pretty effective. So today we have uncovered many of the mechanisms of tumor evasion of the immune system, and at least some of the immune checkpoint blockers, we know they are working in diseases like melanoma and lung cancer. Look at the data here in lung cancer. By using immunotherapy in high expressing PD-L1 tumors, at 5 years, stage 4 patients, survivorship of 1/3, 32%. Remember, with chemotherapy, the initial slide I showed you at the beginning, median survival was less than 8 months, survival at 5 years in the range of 2%. We have here tumors treated with immunotherapy, stage 4 metastatic disease, survival at 3 years, at 5 years in the range of 32%. Immunotherapy is not working alone, it's also working in combination with chemotherapy, particularly on tumors that are not so responsive to immunotherapy alone, such as those with low expression of PD-L1. And even more, we are now complicating a bit more things. Sometimes we are mixing two immunotherapies, even 2 immunotherapies plus chemotherapy for some specific tumors that are particularly resistant to immunotherapy, like negative expressors of PD-L1, squamous cell carcinoma histology, and so we are somehow going into a more personalized type of approach for immunotherapy treatment. Again, as I told you before with targeted therapy, we are also going earlier into the disease. Look at what happened in stage 3. Stage 3, we typically treat patients with chemoradiation, and then we cure about 20% of the patients. Now, after chemoradiation, we give some immunotherapy, and we tend to cure some 40% of the patients. So it's not only improving survival, it's clearly we're impacting on the cure rate of those patients. More recently, we just showed the initial data of combining surgery, chemo, and then immunotherapy. For those patients, immunotherapy prevents the relapse in some 1/4 of the patients. So we are again impacting the early disease by using early immunotherapy treatment. And I think that is what is going to happen more and more into the future. Immunotherapy is going to be part of the initial treatment. Even more, I think very likely we will do immune prophylaxis in the future. We have many heavy smokers that we know if we do nothing, even they stop smoking, many of them, they will develop lung cancer. Lung cancer will still be a major issue for 20 or 30 years until we have completely banished smoking in our media, in our context. And for that, patients, maybe immunotherapy is part of the treatment. Just to give you an example, this is a trial in patients that are, for most of them, smokers. Actually, those were patients, more than 12,000 patients that had a myocardial infarction. Most of them were heavy smokers, and they have data suggesting systemic inflammation with high proteins, reactive protein C. Those patients were randomized for a year of treatment of placebo or 3 increasing doses of canakinumab. Canakinumab is an interleukin-1 beta inhibitor, let's say an inhibitor of inflammation. And as you see here, the higher the dose of canakinumab, the higher the reduction of lung cancer to happen, the higher the reduction due to lung cancer mortality. So maybe into the future, we will do immune prophylaxis. Of course, I just talked to you about a couple of family of immunotherapies, CTL4 and PD-1, PD-L1 inhibitors, but many others maybe are coming. We had not been that successful over the last few years at the time of developing into the clinic some novel agents against novel targets, but hopefully into the future, we will do a bit better. Just 2 minutes on the last 2 words on clinical implementation, which is, this is not easy. More personalized treatment of lung cancer is possible, but it's not straightforward. You need a lot of resources. You need a lot of expertise and knowledge in hospital, because if you like to do so many analyses in so many patients on a specific time frame, you really need people and resources. And this is not happening all the time. Many of the countries in Europe and in other parts of the world can having specific personalized treatment programs. We have not been that successful in this country. If you look, for example, France, they really develop a system with some 28, let's say, oncopoles to do genomic analysis. So regardless you were diagnosed, you have access to personalized diagnosis and treatment. This is not yet happening everywhere in Spain. I think we are moving forward. We are having the initial steps, not similar in every region. For example, in Catalonia, you're a bit more advanced, as in many other things. In that specific case, we have already a program in place that just started a few months ago. That is not elsewhere in Spain, and I think this is something we have to do. We have done a lot of follows with politicians, announcing programs, but things are not yet happening elsewhere. And I think this is something we have to claim for our patients. That has to be coupled with some also strategies of research in that area. There are still many things to do. We have recently the first call of personalized treatment. Some 30 million were given, but for many diseases. We have luckily one program which is, of course, a very small budget for to do many things, but at least is the initial, let's say, ferment to start doing things. Hopefully, the next program will help us to do some other things. The second thing is we need to budget that. I mean, personalized care is not very easy, and it's not very cheap, and we are assuming the cost of the cancer is going to be more and more expensive, and we have estimations that likely we will increase twice what we are spending by 2013 as compared to what we are doing today. Just the final word. This is what happened over the last decade in terms of mortality due to lung cancer. For the first time in the history, we are doing better. We are doing better, less cancer mortality of lung cancer because less patients are diagnosed, because smoking habit vanishes. This is true in US. Here in Spain, still we are smoking a lot, and this is something we have to correct. But secondly, once you're diagnosed of lung cancer for the first time, you're living longer. And this is because we are doing better diagnosis and we are doing better treatments. And of course, this is because we are having some research. And just to finalize, I really like to remember some words of Severo Ochoa, which is was somehow emphasizing that science is always worth it, because at the end, it's always paying back. So thank you very much for your attention. If you have any questions, I'll be happy to share my thoughts. Thank you very much.
Thank you so much, Luis. I think the camera is not working. Okay, thank you very much for such a wonderful talk, such a very nice overview with all the past and the current treatments that have really changed so much over these few decades. No, 1 decade and a half probably. So I have here some questions from the audience. There is one question from one PhD student in our institution that he says this is probably a naive question from a non-oncologist. And his question says, why don't you combine at the same time in the same patient all the first, second, third, and fourth generation drugs to attack all the possible resistant clones simultaneously? Is it too toxic? Thank you.
Yeah, I mean, you know, TKIs are pretty specific, but they are not fully specific. So they are always targeting some other kinases and some other targets at the same time. So toxicity is always there. And every time you combine two TKIs, toxicity is increasing more than additivity. Secondly, we haven't seen that necessarily to be better. We having some data, for example, in the case of Fdfr, showing that the combination of first and third generation TKIs is in some preclinical models of reasonable. The data in the clinic are still lacking. There is a trial by the group of Paz-Ares in Boston that they were the pioneer group of that concept in some cell culturing and mice models, and they are doing some trials on that. That is going to be a bit more difficult in the clinic because you have to be quite a lot better just to compensate the tox issue.
Mm-hmm. That's true. I have a second question that I think when you have talked already about that, but maybe you want to comment. What about all those non-small cell lung cancer cases where there are not any druggable genomic mutation? What do you do?
Yeah. So yeah, for those patients today, let's say what are we doing is mainly immunotherapy alone or immunotherapy plus chemotherapy. That is going to typically depend on how much PD-L1 expression they have, what genomic abnormalities are, let's say, underlying, but this is the typical approach. I think into the future, we will use more and more ADCs as well. You know, we know that there are a number of proteins that are selectively expressed in many cancer cells. Even they are not important biologically, but they are really good hooks to send an ADC. And at least in lung cancer, there are more than 30 ADCs as being developed right now. And already we are having a couple of them with at least 4 with mature data. And I think they are not the holy grail, but they are better than chemo. So I think the way I'm looking at that, and many oncologists look at that, is that every time we are getting a new weapon, we are not forgetting about the old ones, because most of the survival benefit is coming not from a single drug, by the sequence of many alternatives over time.
Mm-hmm. Yes. Okay. One question I have. We know that PD-L1 is not probably a good biomarker, no, to predict response to immunotherapy. What do you think, and what do you think is the status of the current status of the biomarkers in lung immuno-oncology?
Yeah, I mean, PD-L1 is not a good biomarker to say if you are PD-L1 negative, you still may benefit from immunotherapy. Mm-hmm. What is true is that the higher the expression, the higher the likelihood of responding. But of course, the decision should be more multi-parametric, based on clinical grounds and also some other biomarker information. Today, if I'm having a patient which is very high expressors, many patients I prefer to do single agent immunotherapy, but for many cases, let's say, we know that women respond worse to immunotherapy alone. We know that if some genomic alterations underline, let's say, EFR mutation, RET, ROS, ALCA, the possibility of responding to immunotherapy is very low. So just to give you an example, for those patients, likely I will not use immunotherapy alone. I will use chemoimmuno. On the other hand, if I'm having a patient which is adenocarcinoma, heavy smoker, had a P53 plus Carreras mutation, no LKB1 mutation, very likely this patient is going to respond. So I will be confident of using immunotherapy alone. So let's say there are a number of things that are of help. They are not the whole true as well. Even TMB may be of help, but it's not telling all the truth. So I see that into the future, we will do very much a more multi-parametric evaluation of different biomarkers rather than a single one.
Okay, thank you. I have another question from the audience. It says, the results from the CANTOS trial show that reducing systemic IL-1 mediated inflammation improves lung cancer survival. However, you need some inflammation with the tumor to enhance anti-tumor immunity. How does that reconcile?
Okay, well, there are two things which are totally different, and that is very important. When we talk about inflammation, it's important to say which type of inflammation. So we know, let's say, the bad inflammation is pro-tumorogenic. Let's say, we know that you have two patients with lung cancer. One patient is more inflammatory, let's say, we have two patients that are smokers. The one that is developing chronic bronchitis, that is having a more pro-inflammatory phenotype, is 4 to 6 times more likely to develop lung cancer as compared to the patient that didn't have chronic bronchitis. So that means you are more prone to have systemic inflammation, you're more likely to have lung cancer. A second different issue is, and that is typically myeloid-driven inflammation. A second different issue is, let's say, the good inflammation, which is you have a tumor, you like to restore the immune response, you need lymphocytes to be there. Because if you throw a lot of pembrolizumab or whatever to the tumor, but there are no lymphocytes to kill the tumor, you're doing nothing. So that is the good inflammation. So those are, let's say, different things. One is the bad inflammation, the tumor promoting inflammation. The second thing is that inflammation, the immune system that you need to kill the tumor.
Okay, very nice. And I have a final question. Probably we will be implementing the screening for lung cancer patients. So hopefully in the next coming years, the lung cancer patients that will be diagnosed will be mostly early stage lung cancer. So how do you envision the treatment in those cases? Do you think immunotherapy or chemotherapy or TKIs or whatever will be done as much? Or how do you envision the therapeutics will change in this new likely scenario?
Okay, so well, I think that is going to change a lot. So I think, if we discover many lung cancers less than 1 centimeters, the survival at 10 years would be higher than 90%, like breast cancer or colorectal cancer. That is going to be great news. And we know that with the screening programs, more than 60% of the tumors diagnosed are less than 1 centimeter. So this is pretty good news. Second thing is that we will learn on those tumors how to do non-invasive diagnosis. And for that, let's say, it's going to be very important to go a bit deeper into the liquid biopsy analysis. We have to go deeper, like 3 or 4 logs, so that we were able to diagnose on a more efficiently, not only uses genomic analysis, but epigenomic and fragmentomics and so on. And likely artificial intelligence is going to help us as well, radiomics, into the future to have non-invasive diagnosis. So many of those tumors maybe do not require surgery into the future. We will do like stereotactic radiation to 1 centimeter tumors and so on. We also will learn which tumors do need something more by using these minimal residual disease technologies when they are very sensitive. We will know better which patients are requiring only local treatments and which patients are maybe benefiting from extra treatments based on having or not a minimal residual disease after surgery. And those patients maybe would be the candidates to immunotherapy, targeted therapy, and so on. And of course, I think into the future, we will be maybe better at a time of doing personalized immunotherapy. Today, we are only having PD-1 inhibitors, maybe CTLA-4 inhibitors, but just a single family of inhibitors. When we are having maybe 5, 6 different approaches, we will see which one is better for each patient or which combo of immunotherapies is going to be the best matching for a single individual patient.
Okay, very much. Thank you very much. Very, very interesting talk. I enjoyed it very much.
Okay.
That's all. Thank you again.
Okay, so thank you very much for your invitation and for all those questions. Thank you.